Good, wonderful, everybody. Good morning to this session. This session is going to be all about COVID-19, the pandemic response. And with me today are two wonderful speakers. Firstly, we've got Elizabeth Whittaker from Imperial College in London, a dear colleague of mine who is truly the expert and queen of COVID in children. And another speaker with me today is Dr. Caroline Ponmani. She works at Queen's in Romford, which is part of Greater London. And she is both an expert in endocrinology, as well as a pediatric emergency medicine consultant. And she works in one of the bigger hospitals in London. Myself, I'm Nijman. I'm one of the pediatric emergency medicine clinicians, as well as an academic clinical lecturer at Imperial College in London as well. And the three of us will hopefully in the next 2 hours teach you and talk to you about our experience with COVID in children. I will start off today with a talk about how emergency care has changed within COVID and the pandemic response. So this is where we all start. March last year, talking about emergency care during the pandemic, and the world came to a standstill. We learned from China that, maybe children didn't get as sick as adults. We learned from Italy before it hit the rest of Europe that actually there was an issue with number of cases of COVID in adults coming to emergency care. And we all started reorganizing and restructuring our healthcare pathways for children, because nobody really knew, are kids getting COVID? How sick do they get? What is the collateral damage? And do we need to change our pediatric emergency care departments to facilitate our own patient populations? Or maybe do we need to do it to facilitate the adult patient population coming to the emergency department? And I think one thing that we now know 18 months later, and some of it what I'm going to talk about might be a bit retrospective, a bit reflective. What have we done? What have we seen? And what can we learn from that? Because that's what we've done over the last 18 months. We reached out to each other, we shared experience, we entered a virtual world to learn from one another. The number of Zooms where we discussed PPE, healthcare pathways, COVID in children, they were numerous. Let alone this new disease called MIS-C, about Liz Whittaker is going to talk to you about that a lot. So we started thinking about our specialty, and it really gave us a chance to rethink, to reposition. And one of the things early on is what we did is reach out to all our European colleagues. And I'm sorry if this talk is a lot about European healthcare and some of it is North American. If you've got experiences from how it worked in other countries, on other continents, please share that in the Q&A. We'll be very interested to hear about your experiences. But early on, we reached out to sort of our European network of pediatric emergency medicine physicians. And Sylvia Bresson led this work asking about what are you guys doing? This was very early on in the first weeks of the pandemic response. And it was really insightful that everyone seemed to be doing slightly different things. I'm taking here the example of PPE, which has been on the forefront of our pandemic response. And it's sort of illustrative of our various varying practices around Europe. And to today, this is still an issue of debate. Within hospitals, there are different clinical areas doing different things. Within countries, there's different hospitals doing different things. And between countries, the differences are very large. So for example, at the height of the COVID, when I would say that I was wearing a normal face mask, my colleagues in Italy would shiver in fear, saying, why are you not wearing an FFP2 or 3? So lots of differences in the use of face masks on the shop floor. Other protective gowns and gloves, what were people doing? And you can see safety goggles and face shield to the point that some people are not wearing them and others are going full protective gear. And although this is from the beginning of the outbreak, this is still very relevant now. And going forward in this busy winter, what do? We also spoke a lot about healthcare pathways. And this is an example from Padova, where we started streaming patients in green and red zones, suspected or possible COVID, versus green patients. And maybe all of this was really trying to find the holy grail of patient management, because we found out that many green patients accidentally had COVID. A study shown that 20 to 40% of children tested who were admitted to hospital were asymptomatic at the time of testing positive. And then lots of the red, well, look in your waiting rooms at the moment. I'm sure it's the same everywhere in Europe, where the waiting rooms are so full that the red space has become very limited. So we did a lot in our practice within the hospitals. We also did a survey that is currently, has just been accepted, work by Katie Rose, looking at this across Europe. How did we change healthcare systems to really get an understanding how the healthcare pathways towards emergency care changed? There's two things in this graph, which is a scatter plot of the number of changes or the percentage of changes made versus the peak COVID rate of the first wave. Because I think all the changes were made mostly in that first wave, with many people that I speak to across Europe at the moment saying that actually everybody's reverted back to normal practice. But two of the things that we can see in this graph is that actually the number of total changes are very limited in most centers. So out of 15 possible changes that we highlighted, most will have had between 5 to 10% of changes possible. And they were unrelated to the level of COVID in their country. So much more related to the healthcare policy and COVID response than the actual COVID rate in the country. Yet there were a couple of places that did make quite significant changes. One of them being Ireland. So Dublin, they've got a history of 3 pediatric hospitals that as recently are sort of under the umbrella of a single hospital group. And in future, they really want to work as a single hospital site with sort of cross-city guidelines and leadership. And what they did was they closed down one of the 3 hospitals. And they started redirecting from the 31st of March patients to Temple Street and the Crumlin. So they really restructured their care pathways to allow for more capacity at the one site for adults, but also to concentrate the pediatric expertise and competencies in the 2 others. And if we looked at number of patients coming to these hospitals, you can clearly see that the blue line is the one that closed. So as of the 31st of March, there were no patients. On the y-axis, and you'll see a few of these graphs, you can see the number of observed versus expected patients going from a baseline to 0%. The green one is the site that stayed open, but was quite far away from the closed center. So they had a reduced number of patients coming to A&E. And then the red one is the one where most patients got streamed to. So although they initially had a little dip, they then returned to usual activity levels. And from all the places that we have included in our study, and the episode study includes 40 sites in 16 countries, this is the only site or only country where we got data to show that these kind of reorganizations and restructures happen. So talking to them, what did they see? What did they say? Well, they said that actually decisions were made within days. So really rapid decision making. They reached out to the public, so made sure that there was widespread advertising to ensure public awareness of the changes. They did keep an urgent care service center to allow for effective streaming to the other centers. They diverted ambulance service, and they informed primary care. And you can see how this is an incredible organization to make sure it works properly. And 2 standout quotes from the people on site said it was a crash course in integration, but luckily it was eased by a low workload. And that is something to remind, that we saw massively reduced numbers. So this is from all sites together. You can see again, the observed versus expected. The number of children we saw in A&Es reduced greatly throughout the first lockdown period. I'm emphasizing at the moment the first lockdown period because I think that's a really interesting period to learn from change. The biggest change that we saw was, for example, in Austria with 3 sites between 80 and 90% reduction in patient numbers. And what was interesting is that although all sites saw a reduction, each country had their own patterns related to when restrictions happened, what type of restrictions happened. And you can see with Austria, this strong reduction in numbers, and in Portugal, in UK, a less strong reduction, and in Sweden, where we had less rules in place, you actually see a lower reduction of patient numbers. And I can show these figures from a number of studies that have been published from around the globe. Most of them are single or few sites, and that is also important with all the evidence that I'm going to show you to realize where does the evidence come from? Because the evidence from single sites or regions are highly dependent on the healthcare networks that they serve. And in the episode study, we embedded a study called the Resync, looking at children with bronchiolitis. This is ongoing work with initial results from the period from March to March, so the first year of the pandemic. And I think this is interesting because we did not see any bronchiolitis throughout the first 8-9 months from the pandemic. And then earlier this year, with the loosening of restrictions, we saw small peaks coming up in certain countries. By now, we've seen unusual and unseasonal peaks throughout many countries in Europe. But what this has shown us that this reduction in infections has a significant impact on pediatrics and the pediatric emergency care as a seasonal specialty. Because usually we're very busy in winter, many respiratory infections. This is data from America, again showing the first year of the pandemic, comparing it to several years before that. This is 7 sites across the United States, showing no RSV and no influenza in children. So did all presentation reduce? Well, this is some work from François Angoulevent from France, and they showed that yes, in the top left graph, a massive reduction. They published this really quite early in the Clinical Infectious Disease journal. And they saw on the top bottom, common cold, otitis media, gastroenteritis, all went down significantly. But one of the things that they thought they saw was that urinary tract infection remained fairly stable. And we've seen some Swedish data showing the same thing. So that you can argue that not all conditions reduced. And that is an important message because we need to be ready for what is going to come in. Some work that we've just submitted showing the first year of the pandemic and linking data from A&Es to primary care. So this is Northwest London. This is data from a population of about 5 million people that includes 800,000 children. And what you can see in the top left corner is that primary care visitations went down. And then in the top right corner, you can see that that also happens in A&E. You can see that the reduction was strongest at the first lockdown, the first dotted red line, but also with, in Northwest London, the second and the third lockdowns in November and January. In between the lockdowns, in summer, you can see that the number of consultations in primary care and A&E approached normal levels for summer. In the bottom 2 graphs, you can also see the data for hospital admissions, significantly lower than what we saw in previous years, and hospital admissions longer than 48 hours. And there is no uptick there. This system thinking is important because, as said, we serve the health system that feeds patients into your emergency departments. So looking at, do we really see a reduction or are the children just going somewhere else is important. And this is another study from Scotland showing that it's not just emergency medicine that went down. This is also seen in primary care. And this is data sort of until August 2020, where they looked at the first 6 months of the pandemic, and they could see in the top left corner, out of our consultants in primary care went down, ED attendances in the right top corner went down. They saw less admissions. And then in figure D, something important to tease out. They saw no change in surgical admissions. And I've seen this in several other studies. And I think an important message here is that when we make changes to healthcare pathways, whether or not it's to accommodate for a surge in adult population, we need to make sure that people can access emergency care facilities and they can access pediatric surgical care streaming pathways, because they don't seem to be affected as much as some of the other pediatric infectious diseases. And then in graph E, an important uptick in admissions. I've not seen other graphs like this with a significant uptick. I've seen some data from Hungary where they had a policy where they admitted all children with suspected COVID in the first month just because of the uncertainty. But here you can clearly see in Scotland that there was an initial uptick in admissions. And that might reflect something that was a wider concern over the last year and is something of our most important lessons learned going forward in emergency care. Is with lockdown, with concerns about COVID, did children or did parents delay seeking health? And did we see delayed and more severely unwell children coming to A&E? This is a study from Lynn, led by Shamez Ladhani in London, and they did a nationwide survey of children being where physicians thought they had cause for a delay and more severe illness. And you can see the diabetes there is the top one. And Caroline will talk about that a bit later. From here on, there were other studies, and I thought it's recently published, this paper by Conlon and colleagues, a qualitative health system evaluation where you can see that when they interviewed parents about health seeking for A&Es, there was clearly this sign of fear of COVID, the messaging of staying at home. There were physicians saying there are delayed attendances. And they say that actually children with chronic conditions are really avoiding coming into A&E because of the fear of COVID. And both doctors and parents said there is an issue with accessibility of primary care, that they can't go anywhere, that they haven't got a safety net. So was all that we do to accommodate the COVID pandemic leading to harm in children? Were they coming into hospital sicker than before? Well, this is where some work has been done, and our colleague Damien Rowland in Leicester has written about this as well and published a study saying being a bit sicker on presentation or having a cause for delay might not necessarily mean that you've caused harm to the patient at the back end. And in our episode study, when we, for example, look at triage urgency classification, we did not see any significant changes or upticks in children with more severe presentations. We can see the green ones, the yellow ones, the red ones, in all equal manners reduce their attendance rates. And another way of depicting that is here you can see the absolute numbers for hospital admission, PICU admission, and death went down in April 2020 compared to the period before that. This does reflect a relative increase. And this is a phenomenon that we should also take away, is that with the overall reduction in numbers, the children with a severe presentations, they also reduced in absolute numbers, but in relative frequency, they were more common. So there is potential for bias there. Interesting to say that the studies shown over overall childhood mortality over the last year and during the pandemic, I haven't seen any data suggesting that there was an increase in childhood mortality. So as a result of this, we also took on the role of child health advocates, another learning point. Messages from national societies and governments to parents to access care when they felt their child was unwell, that even though there was COVID, that we were still open for business, and that we need to proactively remind parents to look out for signs of children being sick and where to go when children are sick. So moving on from the overall tendencies to A&E, look at COVID in children a bit more. We need to look carefully, and this is why we don't often have spoken about COVID in children. And this is why until sort of the current moment, children have not been at the forefront of the political decision making. At the moment, with the current high rates of COVID, yes, they're important for decisions about vaccinations in schools and testing. But until now, the chances of getting severe COVID from was rare. And in emergency care, we did not have to deal with this often. So one of the papers that was published in Nature Medicine last month showed that in the UK, the mortality rate for COVID-19 was 2 per million children. There were 25 deaths reported on a population of 12 million children across the first year of the pandemic. So really reassuring. Of course, that's completely dependent on the number of children who actually have COVID in your population. And another study, the Charybdis study, showed that about 1% of children who tested positive for COVID were admitted to hospital. And this was based on linking public health data with hospital data and primary care data. And of children admitted to hospital, European data shows that about 13 to 80% were admitted to critical care. So although the risks of severe COVID are small, with current picture being like this, with staggering rates and cases across Europe, and these cases being mainly driven, it seems, by, this is data from the UK, but by the children, we do need to start looking out for them, that we might come across children with severe COVID. And in our A&Es, that also has consequences, for example, for aerosol generating procedures. So what else are we going to see? Well, we spoke about MIS-C, and Liz will talk to you all about that. We also now know that COVID is a multi-system disorder, and you can get CNS involvement because of COVID. You can see it within the context of MIS-C, but important that there's now also some publications showing that actually there are patients coming to hospital with or shortly after a COVID infection who have got detectable antibodies and develop neuropsychiatric disorders. So a really interesting case report just to create awareness. We've seen an association with diabetes, or we think there might be an association with. We know it SARS-CoV-2 infiltrates beta cells. We know that there is a trigger for autoantibody production, but is there a link with diabetes? Caroline will tell you more about that in a second. We know that coronavirus sits in the gut and it can sit there for a long time. So it only makes sense that it could serve as a trigger for example, in intussusception. And initially there were a couple of case reports, but published this month is this overview saying that in literature, there's only 9 cases of intussusception reported. And the evidence is not conclusive. I think it makes sense that intussusception can be caused by coronavirus sitting in the gut, but there's no overwhelming evidence to suggest that we see a very large uptake or children presenting who are more sick than they were before COVID. And very similar for torsion. We know that SARS-CoV-2 can infiltrate seminal tissue. We know that there might be a plausible mechanism for it to cause torsion, but in literature, it's inconclusive. You do see these kind of single-site studies, again, very important to realize. And this single-site study shows a clear increase of number of children with torsion. Some studies also showing that actually the number of children with severe harm are higher, needing more advanced surgical interventions. But other studies seem to suggest that there is no change. So single-site studies see it in the light of a wider healthcare system approach. And for torsion, I'm not sure that the evidence is conclusion. For the last bit, things that we have to deal with in emergency care and things that have really changed in our daily practice is the collateral damage. And we as frontline physicians are in a prime position to deal with this. I think the important thing from this graph, again from the episode study, is that in that initial lockdown, the initial phase of the pandemic, On the right-hand side, you can see again a decrease in absolute numbers of children presenting with mental health issues. But on the left hand, that corresponded to a relative increase of patients we saw. Very similar in this American data set, where they saw a relative decrease in numbers, sorry, an absolute decrease, but a relative increase. But on the right-hand side in graph C, it seems that they were admitting more patients because of mental health conditions. But by now, I think we've got more data from the last year, and especially last winter with ongoing lockdowns. We've got multiple studies, and these are just a few recent publications showing this study from France, number of children with eating disorders coming in. Sorry, this one, number of children with suicide attempts coming in, and this one, number of children with eating disorders. Again, small number of hospitals, but I think these studies are quite illustrative. And it reflects what we've been seeing on the shop floor. So I think what is important there is, going forward, we don't know how big the burden of mental health illness in A&E is going to be. But I think we need to be ready, because these patients typically stay in your department a long time. So we need to start thinking about how to approach the access to mental health service in the community. How do we function as emergency medicine within the wide integrated care model for mental health concerns? And can we find ways of having parallel medical and mental health approaches within A&Es? And I work in one hospital where we've got mental health services on the shop floor, and that really helps with expediting assessments, discharges, and prevents admissions. So good examples to learn from. But it is important more than ever that we start anticipating the burden of mental health issues, especially in adolescence. Our A&Es are not suited for adolescents most of the time. And then they come in with mental health issues and they spend a considerable amount of time with us. So winter is coming, and this is the last bit of what I'll talk to you about today. We are in the middle of winter. And this is what we're seeing. Paper in the Lancet from New Zealand, evidence of an immunity depth. In New Zealand, the moment they opened up the borders with Australia, they saw a resurgence and a bigger peak than before of RSV infections, as well as ITU admissions. I can show you data from Sweden, and this is their current situation, a much bigger and earlier peak of RSV. In England, there's something unusual going on, and it's worth looking at more closely and having a discussion. So if we look at the blue bars, you can see that in England, there was an early, unusual, unseasonal peak of RSV. But if you look at the last blue bar, you can see that at the moment, we are below average of what we used to see in previous years. This is for children who tested positive for RSV. And there is another study, another great example of what COVID has enabled of research. You can see that children in A&E who have a clinical diagnosis of bronchiolitis in yellow, who have confirmed RSV in red, or were tested but negative in the other colors, you can see that by now it looks like the worst of the peak is over. And this also reflects in the number of children being admitted, plateauing, or even going down. So maybe there's a bit of light at the end of the tunnel for the winter to come. Is this just a lull before the storm, or have we seen the worst? So summarizing, how did emergency care change during the COVID pandemic? Well, looking at our current waiting rooms, being full of children with infections and other problems, the whole discussion we had about testing, isolating, care pathways, it almost seems a bit academic. We had empty waiting rooms and plenty of time to Zoom each other and talk about this. But it did allow us to connect, to think this through, to prepare. And there's many, many places where we can learn from excellence in care. We had a position to rethink our specialty, to reposition emergency care within wider integrated care networks. I think it is important that we got used to rapidly developing an adaptation of protocols and pathways. And it gave us permission to innovate in our specialty. And importantly, I think we had a way of accelerating research in emergency medicine. And that's what we've seen over the last year, not always of high quality, but we've seen an enormous output from emergency care to reflect what was happening with the COVID-19 pandemic and child health. And probably the most important takeaway message is that in our current tsunami of children with COVID, with other respiratory infections, we don't know where this is going to go over the summer, over the winter. But what we have learned is that COVID-19, that with simple non-pharmaceutical measures such as wearing a mask, washing your hands, socially distancing, staying at home when you've got a cough and a fever, we have found a way to significantly reduce the burden of acute childhood illness. We can stem the tide by simple intervention if for one reason or another the system gets overwhelmed. And that will be a public health and a political decision, but we need to be the advocates of that. And I think with so many children having COVID now more than before in the pandemic, we now also need to think about, you know what, the rare complications of severe COVID or COVID-associated disorders. They are rare, but they do exist, and we need to keep them in mind. And there's many unknowns with research rapidly developing, and we just need to stay updated, think wide and broad, and see what's at the end of this tsunami. I thank you all for listening. I don't think there's time for questions at the moment, so I'll stop sharing and then I'll introduce Caroline Ponmani for the next session. So Caroline is a good colleague of mine. She, as said, she works at Queen Romford in the Greater London area in a very busy and multicultural emergency department. And she will talk to you about diabetes and the link with coronavirus. And she does that from a background of being both an endocrine expert as well as a pediatric emergency medicine physician. Caroline, here you go. We can see your slide.
Thank you, Ruth. So I'm Caroline. I work in the Children's Emergency Medicine Department, which, as you know, is a rather exciting and quite a wonderful place to work in. Things got curiouser and curiouser for us with COVID, and we saw an extraordinary amount of pathology. I'm also an endocrinologist, and in the COVID-19 pandemic, I had a ringside seat to observe the children presenting with diabetes to the emergency department. So this really is the story of pediatric diabetes in the pandemic, as seen through the eyes of the emergency medicine clinicians, with perhaps just a little touch of endocrinology. The spotlight has been on pediatric diabetes, mainly for 4 aspects: a reported increase in the incidence and severity of DKA, a reported increased incidence of new-onset T1D, concerns that all this is in some way related to SARS-CoV-2, and there have been real concerns about delay in presentation in the pandemic. So we're going to explore all these 4 aspects with a mixture of qualitative and quantitative data, starting from single center to multi-center, literature, and finally a nationally representative data set. We know, as Ruth said, that the COVID-19 pandemic has resulted in significant changes in the healthcare system. This was particularly visible in ED. On one hand, you had the adult services completely overwhelmed with sick patients. Right next door was pediatric ED, where you had unprecedented and dramatic decline in pediatric attendances, the kind we've never seen before, and probably we will never see again. This is a data set from the hospital that I work in. We see about 43,000 children in a year in pediatric ED. And you can see here the dramatic reduction in 2020 compared to 2019. In September 2020, we thought to ourselves, this is going to be a very busy winter with COVID thrown into the mix of endemic winter viruses. But as it turned out, that wasn't the case at all. Attendances continued to plummet, and with the announcement of the second lockdown, they fell to this level. But amidst this menu of reducing pediatric attendances, what stood out was the story of pediatric diabetes. Again, there's a single center data. The center has 375 children with diabetes, and normally we see about 40 to 45 children in a year. You see a peak with winter viruses, then you have a little lull in summer when the endocrinology types like us put our feet up. But that was not to be. In July 2020, we were seeing 2 to 3 children come in with the moderate to severe decay. Some of them were in shock, some needed PICU. So a bit unusual, really. So the question that we asked ourselves is this a true increased incidence? Or is the disease acuity so much that it looks so impressive? Could COVID be a suspect here at all? Or do these children appear prominent because of the lack of dampening effect of the many, many sick children that we normally get in ED with this marked reduction in ED attendances? At this point, there was no literature that was available to report on pandemic data and pediatric diabetes. But there was a signal from adult medicine and from adult ED, a proposed relationship between COVID-19 and diabetes in adults. There was hypoglycemia reported in 50% and decay in 33% in adults with diabetes with confirmed or suspected COVID-19s. Studies also said that even in the absence of a diagnosis of diabetes, there was still an association between hypoglycemia and severe COVID-19. Before we delve into the pediatric data, I just want to look at diabetes through the eyes of the endocrinologist. So when we say pediatric diabetes, 96% is type 1 diabetes mellitus, which is a little different from adult diabetes, where about 92% is type 2 diabetes. In pediatric diabetes, out of the rest of the 4%, 2% is type 2, and the other 2% is monogenic, undifferentiated or complicated, like that associated with cystic fibrosis, for example. What happens initially is a seroconversion in response to an environmental agent. But the most important line in this slide is a genetically predisposed individual. So we have a limited cohort of children who are genetically predisposed to get type 1 diabetes. We think that viruses trigger the autoimmune response, but it's never been possible to completely implicate viruses, simply because that critical infectious event, which happens to trigger the seroprevalence, happens months to years before type 1 diabetes symptoms present. The only real evidence are in patients who had congenital rubella syndrome and then went on to develop diabetes. And there's been a lot of studies about Coxsackie virus as well, but nothing conclusive there. Many prospective studies, including TEDdy, showed us how the natural history of diabetes evolves, and this is a graphical representation. So you see, this is the point where seroconversion occurs. And if it happens before 2 years of age, then it is thought that the child will ultimately manifest with type 1 diabetes at some point. But you can also develop an antibody and end up not manifesting type 1 diabetes at all. You see in this segment of the graph, you can see that tolerance is re-established. If you have more than 2 antibodies, then there is a chance that you will develop type 1 diabetes. About 60 to 70% will. So the chances of developing overt diabetes symptoms depends on the magnitude of the autoimmunity as well as the age at which you seroconvert. After seroconversion, there is a quiet period in which beta cells are destroyed. And finally, when a critical mass is destroyed, you get frank symptoms of type 1 diabetes. But the entire period can take months to years. Coming back to the original data, where we asked the question, is there increase in pediatric decay in the pandemic and is SARS-CoV-2 accountable? So we looked at data from January to August 2020 and compared it to the previous 5 years. All these children presented to the emergency department with new-onset diabetes. And in this study, we were looking at only type 1 diabetes, not at type 2. And you can see that the characteristics of the children, the age, the ethnicity, there was no variation there. Even with the diagnostic interval, didn't seem to vary much. But what stood out was the increase in decay, both in numbers as well as the acuity in 2020 compared to the previous years. Then, of course, you want to explore to see if there is an actual increase in the incidence of type 1 diabetes. But that isn't really the case. You see, there are 26 cases from January to August 2020, but this is comparable to 2016 to 2020. There isn't a dramatic increase in cases as such. Normally, when we plan services, we expect a 2 to 3% increase in the incidence of type 1 diabetes. And although this is a high incidence here, there isn't an overt increase. When we look to the total year, when we think of the number of children we get in a year, which is 40 to 45, we had 58 children presenting from April to April, 2020 to 2021. It was a high incidence year, but not dramatically so. And that brings us back to that original word, genetically susceptible cohort of children. We set to explore this question through the Pediatric Diabetes Network. This was a study that was done across 12 hospitals across central London, Kent, and Brighton. And many of these hospitals were in the epicenter of the COVID-19 pandemic. We looked at the characteristics of 179 children presenting in 2020 and compared that to 149 children presenting in 2019. And the characteristics did not change much in terms of age, ethnicity, diagnostic interval to presentation. Again, what stood out was decay, increase in the numbers who presented in decay in the pandemic. In absolute numbers, 2020, we had 79 children presenting across these 12 hospitals compared to 49 presenting in 2019. When you looked at severity, there was increase in moderate and severe decay. Again, you have to look at 5 years worth of data to get a true picture. And here you see again that about 25 to 32% presented in decay from 2016 to 2019 in these 12 hospitals. And this is only first wave data. We're looking at only January to July 2020 in these hospitals. Whereas in 2020, there was a significant increase in moderate and severe decay. Then you look at actual incidence. There is a peak with winter viruses that we see. Spring is a bit of a quiet time. There's a trough here. Again, there is a secondary peak in June and July, similar to the Unicenter data that I showed you. So the conclusions were that there is an increase in the number and the severity of children presenting with decay diagnosis from the diabetes network. Delay in diagnosis was not a significant factor in decompensation. And I'm talking about the median period here. The median diagnostic interval was the same across both years. In fact, slightly lesser in 2020. Of course, there will be outliers, but delay did not appear to be a significant factor in decompensation. 2020 was a high incidence year for the network, but there wasn't a dramatically increased incidence in the number of children presenting with new-onset T1DM. We did see a number of index cases when we did this study, which showed us a little more about how SARS-CoV-2 was affecting these children. Patient 1, she's a 10-year-old Caucasian girl. She had symptoms of polyuria and polydipsia. She developed this during the period of lockdown. Parents thought she was bored and she was eating and drinking a lot. They also noticed that she had weight loss. They noticed this retrospectively after she came in decaying. So you see, there is already an inbuilt delay in recognition of type 1 diabetes symptoms. In May 2020, she initially started to have difficulty in breathing. Parents correctly identified this, took her to the GP. It was thought that she had asthma and a salbutamol inhaler was prescribed. Within 24 hours, she deteriorated. She had slurred speech and difficulty in walking. Again, parents correctly rushed her to EME, having realized that she was quite ill. When she came here, she was in severe decay, in fluid refractory shock. Her GCS was 11. So a diagnosis of new-onset diabetes was made, and cerebral edema was suspected. PIMS was also suspected, so her CRP was 215. Now, her RT-PCR was positive for SARS-CoV-2. Initial treatment was started in the emergency department and she was transferred to PICU. But actually, she did very well. She stayed there for 4 days. She did not need treatment for cerebral edema. She did not need treatment for PIMS. She did not fulfill the criteria. So she's treated with fluids and insulin, went on to make a full recovery, and she's now on subcutaneous insulin. She also had antibodies to ICA and GAD, indicating that here was a child who already had a predisposition to develop type 1 diabetes. The second child, this is a teenager, an Afro-Caribbean child, who had 2 weeks symptoms of polyuria and polydipsia before developing pain, abdomen, and vomiting. The parents discussed this with 111. They were told to keep her well hydrated. Again, the deterioration was rapid. Within 24 hours, she became unresponsive and she was rushed into ED. When she came to ED, she was in severe decay, in shock. GCS was 9, cerebral edema was suspected. And after the initial treatment in the emergency department, she was sent to PICU. She did very well in PICU. In 48 hours, she was transferred to the ward. The only thing is in PICU, she had severe pain abdomen, which needed IV medication. So they ran a panel of amylase and lipase. Amylase was 1,200, which is quite raised, and lipase was 350, also quite raised. So a diagnosis of pancreatitis was made. We also realized that this child had a markedly raised FT4 and a suppressed TSH at presentation because she came in so severely and we hadn't noticed that. And then when she came back to us to the ward, we ran the thyroid function tests again and also ran thyroid receptor antibodies. And thyroid receptor antibodies were quite raised, indicating she also had Graves' disease. So here were 3 pathologies going on: new-onset type 1 diabetes, thyrotoxicosis, and also pancreatitis. Again, her RT-PCR was positive for SARS-CoV-2, and she had ICA and GAD antibodies, indicating that she too had a predisposition to type 1 diabetes. So that brings us back to the original graph. Here were 2 children who had antibodies suggesting that they were predisposed to type 1 diabetes. They were already at this point manifesting overt diabetes symptoms. The question is, was SARS-CoV-2 the critical infectious event which pushed them off the edge over here into severe decay? A study came out in February 2021, which showed that SARS-CoV-2 could infect and replicate in the cells of the human endocrine and exocrine pancreas. So one wonders whether the second child that I described is showing an in vivo manifestation of this study really. We had a third child. This is a this is a Bangladeshi boy. He was overweight. His weight was 83 kgs, 15 years old, with a BMI of 28. He had 10 days of polyuria and polydipsia, and then developed pain, abdomen, cough, and fever. So when he came to the emergency department, he was not in ketoacidosis, but blood glucose was markedly raised at 44. His CRP was again more than 200. PIMS was considered. He was started on fluids and insulin, and he remained in the ward. Then he started to deteriorate in 2 days' time, shooting with PIMS too. Echo showed a markedly impaired function. He also became quite combative and aggressive. He was transferred to PICU. He was treated for PIMS according to the recovery trial protocol. And he did well. After 72 hours, his symptoms improved. Now, he did not have antibodies for the type 1 diabetes, but he had a strong family history of type 2 diabetes. So with him, the diagnosis was type 2 diabetes. But you see, he already had symptoms of polyuria and polydipsia. And one wonders whether the hyperinflammatory pathway of PIMS pushed him to develop these severe manifestations. Again, he's doing very well. He's still not subcutaneous insulin. We haven't been able to change him to metformin as yet. By this time, multiple studies came out from literature internationally. The first was a registry study from Germany looking at 532 children. And the main finding of the study was increase in decay and increase in severe decay. At the same time, they did not find a significant difference between observed and estimated incidence in type 1 diabetes. Then you had a study from Italy. In this study, again looking at first wave data, there was a 23% reduction in new-onset diabetes cases. But among the children who presented, they had an increase in decay and in severe decay. We had a study from London, from Imperial, which looked at 30 children. And this study reported that a high proportion of children were presenting in decay, also in shock and needing PICU. There was a fifth study which came from Great Ormond Street. Again, this looked at 30 children and first wave data reported similar findings with increased decay. Now, wouldn't it be lovely if we had a study which had a large data set, let's say about 2,500, looking at children across the first and second waves of the pandemic and comparing it to the pre-pandemic period? That brings us nicely onto Dimples. This is a Peruki study which does just that. So we looked at children with new onset and existing diabetes across both waves of the pandemic, presented to the emergency department in the SARS-CoV-2 pandemic and also in the pre-pandemic era. The study was done across both UK and Irish children's emergency departments, and we do have that 2,500 data set. I won't be talking much about dimples, but I will give you a little preview of children who presented with new-onset diabetes and DK. So this is the dimples data set. You can see from March 2019 to December 2019, the number of children who presented in DK is lesser compared to the 2020 data. You have the peaks in June and July in 2020, and also in September and February 2021. So in absolute numbers, 322 children presented in DK with new-onset diabetes in 2019 versus 471 who presented in 2020-21 with new-onset diabetes. But we don't have much data about increase in episodes of DK in children with pre-existing T1DM. Perhaps there is a parental supervision and increased compliance with insulin injections. Perhaps that made a difference. And other factors like erratic eating was there, sleeping patterns in lockdown, reduced activity and psychological factors in isolation. How all of these factors balanced each other and how they affected T1DM. Did they precipitate T2DM in children? We don't quite know that. We do have some data from dimples, which I think perhaps needs another talk. Then comes the final bit, establishing causation. It's always been difficult to establish association and causation with viral triggers, suspected viral triggers. We know the definitive test for COVID-19 is the detection of SARS-CoV-2 RNA by RT-PCR, but that sensitivity varies between 71 to 95%. The specificity is quite high at 97%. So much depends on the diagnostic testing window, the technique, and the viral loads. Then we have serology. Now, serology would show past exposure to COVID, but it isn't very useful in proving causation as such. There is a third arm as well, the discordant T cell and antibody responses. Studies have shown that even people with laboratory-confirmed SARS-CoV-2 may not develop antibodies to COVID-19, but instead have T cells reactive with other SARS-CoV-2 antigens. So testing itself complicates the problems with establishing association and causation. And finally, the delay in presentation question. We already know that there is an inbuilt delay in identifying the symptoms of diabetes. That was present in the pre-pandemic period, but a number of factors contribute to it. Lack of parental and clinician awareness. And children under 5, they can present with quite non-specific symptoms. They're not that easy to diagnose. But there is one aspect, that delay in referral while attempting to confirm the diagnosis. That is the aspect we need to work on. But that is on a separate note. In the COVID-19 pandemic, what we want to know is, has the delay been because parents are afraid to come to ED? Because of catching SARS-CoV-2? Have system changes contributed? We have some answers for you from the dimples dataset. So in a year where there was a dramatic decline in ED attendances for infection, there was this unusually high prevalence and severity of DK in children with new-onset diabetes. So the question is, does COVID unmask diabetes in a genetically predisposed child? I don't have the answer to that. The interpretation of DK is quite complex. Interpretation of DK in the COVID-19 pandemic, simply because there have been a number of system changes in the pandemic, and there is this proposed diabetogenic effect of SARS-CoV-2. So really, the true story may take many, many years to emerge. But in the meantime, we know DK causes significant morbidity. DK also causes mortality, and it is preventable. So early recognition of type 1 diabetes is really vital to prevent these children from going into DK. And this is especially important for children of emergency and primary care clinicians who see children in the early phase of the disease. They should modify their index of suspicion. Is it easy to detect these children who present with T1DM? Even as an endocrinologist, I can tell you that it isn't, because it presents quite non-specifically. But even as research continues, we try to work out the etiopathogenesis of the disease, try to find out the points where we can intervene, perhaps slow down the disease process. We need to press on. We need to remain increasingly vigilant and prevent these children from going into DK. Thank you.
Great, thank you, Caroline. I think we'll do questions at the end, if that's all right with you, and we'll move on to Liz Whittaker's presentation. And after this fantastic presentation from Caroline, Liz, it's an honor to have you on this session. For those who haven't come across Liz until now, she is a pediatric infectious disease consultant at St. Mary's Hospital in London. And in the UK, she's been one of the pinpoint figures in the COVID response for children. And she will bestow on us her wisdom and her experiences. And please share any questions you have in the chat. We'll have a bit of a Q&A at the end, and I'm sure there'll be many, many questions for both Caroline and for Liz. Liz, there you go.
Thanks so much, Ruud, and that's such a lovely introduction. It's slightly embarrassing, and I have to say, after both of your beautiful presentations and your gorgeous photos, I feel like this is going to be a less glamorous presentation, I'm afraid. So thanks very much for introducing me. So I'm going to talk a little bit about PIMS or MIS-C, what it is, what we know about the pathogenesis and the immunology so far, some diagnostic advances that have been made, what the treatment evidence is at the moment, and then just a little bit at the end about how the brain is involved, and is there a relationship between long COVID and PIMS and MIS-C, or is that something we should explore? And if there really is time at the end, and I'll set a timer now, I have a couple of slides on myocarditis and the vaccine, but I think we might not make it there. So I have presented this presentation before. This is just a kind of vignette of a child presenting with PIMS. As you've heard from Ruud, COVID doesn't affect many children, but a very tiny proportion of them do get this quite devastating condition. And so this 11-year-old girl presented with 3-day history of fever, abdominal pain, diarrhea, myalgia, and neck swelling, and was admitted to her local hospital where she had a high CRP, and there was concern about abdominal sepsis because of her tummy pain. And she was seen by the surgeons and had some imaging which showed that she had fluid in the right iliac fossa, and some small lymph nodes in her mesentery. She was given some broad spectrum antibiotics, but unfortunately deteriorated and required fluid resuscitation, and was admitted to our intensive care unit at St. Mary's, where she was put on to triple inotropes in quite quick succession, and despite that remained hypotensive. Because we wondered if she had toxic shock syndrome, she was given IVIG, and she had an echo which basically showed her heart wasn't pumping effectively at all, and her bloods were rapidly deteriorating with the CRP doubling to 300 and a very high troponin. She had a positive PCR, which I'll go on to tell you is relatively uncommon in this cohort, and our differential was broad, worried about sepsis. Was this an atypical adult presentation of COVID? Was it toxic shock? And she transferred to Great Ormond Street for ECMO, and actually, to be honest, she crashed onto ECMO, was lucky to make it on, and was treated with high-dose methylprednisolone for 16 days, and actually was then extubated, and with remarkable normal cognition and completely normal cardiac function at that time, so had made a complete recovery. She had some complications of intensive care, including myopathy and a thrombus, but actually went home about 10 days later. So this is just an example of the sphere end of the spectrum of PIMS or MIS-C. They're not all this sick, but when they are and you're in A&E with them, it's pretty scary. And so we described this condition called pediatric inflammatory multisystem syndrome in the UK because we like PIMS and it was the summer, or multisystem inflammatory syndrome in children, or MIS-C if you're anywhere else in the world, as far as I can see. And we published this paper in JAMA about the first 58 children that we described in the UK. So these kids present with mucocutaneous changes, which means they have red palms and soles. They have rashes, which can be urticarial or maculopapular, or really quite angrily erythematous, and they get very erythematous conjunctiva with no non-purulent conjunctivitis, but as well as that, they can have red lips and tongues. And there's this lovely infographic on the Don't Forget the Bubbles webpage, which you can go and have a look at, and they present with a selection of symptoms like the patient I presented, but also with headaches and encephalopathy. And about 40% of them are quite severe and end up in intensive care because of shock. They can develop ECG abnormalities with arrhythmias, and about 12% of the children have dilated coronary arteries, although thankfully many of those resolve with treatment within a few weeks, and bowel inflammation is present in about 80 to 90% of these kids. So very, very inflamed. And a very classic blood picture that we see with low lymphocyte counts and high neutrophils with very high CRPs. We've seen CRPs up to 700, which isn't something I've seen with any other condition before this. They're very sick, they have a low albumin, and they have coagulopathy with a high fibrinogen and high D-dimers. And then a subset of them have myocarditis with a high troponin and a BMP. Although we think more recently that the BMP is often driven by fluid resuscitation, and these kids don't do well with aggressive fluid resuscitation. So if you manage them nicely, they are often a little bit dry because of the diarrhea and fevers for a few days when they present, but don't need huge amounts of fluid, but need inotropes instead. And they often usually have a negative PCR, but a positive IgG, suggesting this is a post-infectious phenomenon. And how common is it? So this American study has looked at that in the US and suggests that there's about 300 cases per million SARS-CoV-2 infections, and modelling on some of our UK data would suggest it's about 1 or 2 per 5,000 infections, which is a very similar number. Actually, now that we have capacity and are testing children more often, given so many of them are asymptomatics, we've been screening the adolescents in particular for school, I think this is probably more like 1 in 8 or 10,000. And because at the beginning, you know, we just weren't testing young children because they didn't need it. So the denominator was always a bit hard to pick up. And this study, which was looking at where these kids were in the US, showed very similar pattern in terms of the gastro and the rash and shock. These were a slightly more unwell cohort, but they showed that the majority of these patients are Hispanic or Black. And in our setting, the majority of patients are Asian or Black in the UK. And I think that they're disproportionately represented. And interestingly, in this study, the majority of cases are in cities or in metropolitan areas. And I think that this has looked very much like a disease of poverty or deprivation, in that if you are, the more exposed you are, particularly in the first couple of waves, the more likely you were to develop MIS-C or PIMS. And we think that that is reflected by the ethnic demographics. There is an ongoing genetic study to try and understand if there are genetic predispositions, and I think that's a reasonable suggestion, given that it's so similar to Kawasaki, which is obviously named after Dr. Kawasaki in Japan, and we know that being of East Asian extraction means it gives an increased risk of Kawasaki, so it would be reasonable to think that this kind of cousin syndrome might be more common in some ethnicities, but I think we need more data to prove that. And this is a slide of Professor Michael Beans here at Imperial, just with the comment that if you've got a big thing like an elephant and you're blind and you only ever hold the trunk or the tusk or the tail, you will describe something that's slightly different. And certainly in the first period of describing PIMS and MIS-C, everybody had a slightly different take on what it was like, because if your patient, you saw lots of encephalopathy, you would think that that was the problem. If you thought it looked like HLH or macrophage activation syndrome, you would describe it as that. If you saw a younger cohort who looked like they had Kawasaki's, then it's reasonable to think it looks the same. So it's taken a little while to get the full picture of the elephant, but I think we have a really good idea at the moment. And one of the questions that we've always asked is PIMS or MIS-C the severe tip of the iceberg, so just the group that are really obvious because they're so unwell and come to A&E, and is there a wider spectrum of milder illness that doesn't make it to medical attention? And I think there is certainly a group of young people who have an undifferentiated inflammatory syndrome and get better by themselves. But I don't think it's as big as we thought it could be when we first started describing this condition. So following SARS-CoV-2 infection, there are a number of post-inflammatory or outcomes that can happen. So the vast majority of children will experience asymptomatic or mild disease, and a small proportion, particularly those who are older and more adult-like in phenotype and obese, may experience COVID-19 with pneumonia and have a positive PCR. There is a group who have been described to have COVID